So the taller you are, the bigger your lungs are gonna be. Oh, I'm the doctor. Hey. I documented it all. What happened, Randy? Check my documentation. It's all in there, man. I said no. You told him no. I told him hell no. And he's Big Money Bound TV, RRT Posse YouTube. If you're new to the channel, please like, subscribe, and turn on post notifications. I release scheduled videos every Monday, 12 o'clock a.m. Eastern Time. But I also release some unscheduled videos throughout the week. Now, if you're returning, hey, welcome back. I appreciate all of the support, man. Thank you. Today's video, I'm going to tell you about the time a doctor ordered me to go kill a patient. No, ordered me to kill a patient. How? What? All you got to do is keep watching. What we represent, man?
Big Money Bound.
Say, let her know, man.
Big Money Bound.
We got the kids, man. So I was in the ER. Y'all know I was covering the ER. I'm an ER respiratory therapist. You know, I can do that. I can work over here. I can work over there. But this particular night, I was covering the ER. Everything was going smooth. I was having a good night. It was one of those chill, downtime kind of nights. Like, wasn't too busy. But it don't stay like that for long. When you're in the ER, you gotta stay on your toes, man. So I'm down there. I'm chilling. Everything going good. Randy, can you give a breathing treatment over here? Give an ABG over there. Hey, that's no problem. I can do that with ease. That's my pleasure. Then I get a call. I get a heads up. Hey, man, we got a priority 1 coming into room 24B. Can you go over there and set up your vent and be ready when the patients get there? All right, that's no problem, man. Let me go over there. Let me do that. So I'm in there. I'm setting everything up. I'm getting my ET tube ready and everything because normally the normal size ET tube that you use is going to be a 7 or a 7.5. The one that's normally used is a 7.5 tube. So I got a 7.5 tube ready and a 7 just in case. Patient rolls into the room. I see it's a patient between like 4'11" and 5'2". But the patient is like 300 pounds. Now you 4'11", 5'2", weighing 300. You weighing 300. You gonna be kind of like a beast. You know what? It was an obese patient. 4'11", 300 pounds, obese, real life obese. So we intubate the patient. Intubation is a little bit difficult because when you that like big, but you that small, your neck is still kind of like stubby. And it's like, those are the most difficult, those, I don't want to say no neck, but kind of like real small, invisible necks. Can we say invisible? This is serious, man. The neck was invisible. So it was a difficult intubation. First we tried the intubation blade with just the blade. Then we had to go and get the glide scope. The glide scope is a blade that has an actual camera on the end of it, so you can see through the trachea, through the epiglottis, or you can see through the trachea and the epiglottis. Once you lift up, you can see the vocal cords. So then you can insert the tube in the right place. You feel me? You pass the vocal cords and you stop. So you can actually see where the tube is going. So that's what we had to wind up doing. We did that. I checked the breath sounds. The tube was placed at about 24 centimeter mark. Anybody who knows the ET tube, 24, 25, 26, 27, 28, that's on the deep end. If the patient is short, the tube shouldn't be that deep, because to get from your vocal cords through the trach and to ventilate the lungs, it's not going to be a long distance to travel because you're so small. So it should be at around like 18, 19. I think we pulled it back to like 18 or 19. So we pulled back a couple of like, a lot of centimeters, like 5 or 6 centimeters we had pulled back. So that's good. Intubation is good. I secured the tube with the Hollister. And now we ambuing. I'm waiting for the doctor to give me the vent order, so he's right there. Doctor saying, okay, I want PRVC. That's pressure regulated volume control. PRVC 100%, which is 100% oxygen is the standard whenever a patient has just been intubated. So 100% oxygen, PEEPA 5, and I want a tidal volume of 625. Whoa, buddy. A tidal volume of 625 is for a big patient, like height-wise. Those are for big lungs. If you're a small person, you don't have big lungs. Tell me everything, but the patient is big. They're 300 pounds. Your lungs go vertically. So the taller you are, the bigger your lungs are going to be, the more tidal volume that you're going to need to ventilate your lungs. Just because you're big and wide, that don't mean that your lungs are bigger. It doesn't work like that. So I'm trying to tell the doc, I'm like, nah, I think 625 is going to be too much. Doc is telling me, man, that's what I want. This is the big patient. I'm like, hey man, like the lung size goes by your height, not your weight. This is a wide patient, I agree with you, but the lungs don't expand like that, man. You don't want to give 600. That's gonna, like, you may pop a lung. Oh, I'm the doctor. Hey. If it's something that I don't agree with, I'm not finna turn no vent up to something I think is gonna hurt somebody. That's not what I'm gonna do. Hey now, I told you what I recommend. I'm the respiratory therapist, but you are the doctor. Now everybody heard me say, I don't think we should do that now. So y'all heard me now. I don't think we should do that. Now you wanna do that? Go ahead, but I don't feel comfortable doing that. All right, then I'll do it. Whoop. Hooked up the vent. We turned it on. Bing. As soon as we did that, the peak pressures went to screaming. It's too much pressure inside of these lungs to this kind of ventilation. This is bad. Start looking like, wait, so what's going on? Can you adjust the alarms? No, I can't. I can't adjust no alarms, dog. The alarms are set to the appropriate setting where I know if there's something wrong. And there's something wrong right here, man. I ain't gonna turn the alarm up to 855 where it's never gonna reach, knowing that there's something wrong going on here. So I'm like, nah, I can't do that. So, what settings should I put? Okay, hey, thank you for consulting me, man. Hey, bro, I got you. Just talk to me. Doc, I think we should do 400. 400, hey, this lady, 4'11", 5 feet. Let's do 400 and let's see where we at. All right, no problem, let's do that. So we do 400 and I increased the rate to like 22 because the patient was like down for a while. And like I said, whenever a patient is down for a while, they haven't been ventilating properly. So the CO2 in their blood going to their brain is very high. And you want to blow off that CO2. And to blow off the CO2, you got to increase the rate. Just blow it off. So I'm documenting, charting everything, saying what happened. Then in like 15, 20 minutes, I get an ABG, check the blood gas to see what's the patient's current values. And it was a while ago, so I don't know the exact values, but I know that it wasn't like too far out of normal range. So the settings that we had to be tweaked just a little bit, but it wasn't nothing like too extreme and too dramatic. So that doctor didn't literally say, go kill that patient. But the orders that you given to put in these vent settings, you could literally like hurt a patient so bad that you could literally like, kill someone. And like, if you don't feel comfortable doing something, you know that maybe this isn't right, do not do it. Don't put your license in jeopardy because somebody gave you an order that you didn't think was right, man. You got to protect your family and your well-being. If this is how you provide for your family, this is how you're going to provide for your family, protect this at all costs. Like, you in that program going hard, studying, stressing out, man, having your head hurt. I remember all them headaches I had. You think I'm finna come here and just throw away everything I worked hard for? The house, the this, the biz, the car, the love of my life. I'm finna put all that at risk and jeopardize that. Now I can't provide for my family. Oh no, not me, dog. Hey, not me. Do what you want to do now. I'm documenting. I recommended that we do not do this. This is not clinically appropriate at this time. I documented it all. What happened, Randy? Check my documentation. It's all in there, man. I said no. You told him no. I told him hell no. And he's so, hey, man, if you don't feel comfortable doing something, don't do it. That's just the bottom line. I appreciate all of the support, man. Thank y'all for watching so much. RRT Posse, I got us. Thank you.